Hello and welcome. We're discussing IVF add-ons, building bridges between clinics, regulators and patients. And the hashtag for this event is Pet Add-ons. This discussion event has been made possible thanks to the kind support of the British Academy. I'm Sarah Norcross, Director of PET, and I will be chairing the discussion. Add-ons are optional treatments, technologies, or procedures offered alongside fertility treatment, usually IVF, often at a considerable expense to patients, and which may or may not be supported by reliable evidence. And this event will be discussing the project Building Bridges Between Fertility Patients, Clinics and Regulators, a collaborative approach. And this collaborative approach part of the project is particularly important because the project has really tried to avoid the usual dichotomy of add-ons are bad, ban them, and add-ons are good, give them to everyone, and to come up with something more conciliatory, something that is a more pragmatic solution, or would be a pragmatic solution. And the project has been led by Dr. Manuela Perrotta, who is based at Queen Mary University of London, with the funding from the British Academy, and PET is a partner in this project. And the three key aims of the project were to identify the key needs, the priorities and challenges related to fertility treatment add-ons for various stakeholder groups, so for the patients, the professionals and the policymakers. The second aim was to develop original approaches to manage identified challenges. And the third was to produce a feasible set of proposals to address the key challenges that we found. And as part of the project, in addition to an extensive literature review, we have held 7 different workshops, including a very diverse range of stakeholders, people who work in the clinics, patient advocates and charities, chief execs and business managers of clinics, regulators, including as well as the fertility regulator, the Human Fertilisation and Embryology Authority, the Advertising Standards Agency, and the British Medical Association. We've also involved ethicists. So all in all, there were over 70 participants who registered or attended in total. There were some people who attended more than one workshop, so we have overcounted slightly there. But we had a lot of people with a lot of wide-ranging views. And from these workshops, we've produced 3 research digests, and there'll be links to those in the chat, as well as a toolkit containing 14 proposals. And the most important of those proposals, Manuela, our first speaker, will be discussing in more detail. So let's find out more about the project and hear what the other panelists think about this new bridge building approach that the project has taken. It gives me great pleasure to introduce Dr. Manuela Perrotta, who's a principal investigator at the Building Bridges project, and she is leader of the Remaking Fertility initiative. She's a reader in technology and organisation at Queen Mary University of London and author of the forthcoming book, Biomedical Innovation in Fertility Care, Evidence, Challenges, Commercialisation, and the Market for Hope. She has published research on many aspects of IVF and add-ons, including the extent to which the UK fertility websites comply with guidelines and the extent to which a consumerist model dominates both public and private fertility treatment.
I'll be presenting key highlights from the research project Sarah introduced, which aim to engage various stakeholders to identify the key needs, priorities, and challenges, ultimately fostering collaboration and building bridges between these groups. In the first stage of the project, I conducted a secondary analysis of extensive data from my research group and others. This analysis highlighted 3 main themes which were discussed in initial workshops: the effect of evidence gaps on information quality, the provision of information on fertility clinic websites, and the lack of transparency regarding treatment costs. Detailed discussion are available in Research Digest on our website, linked in the slide and shared in the chat. Here, I'll briefly outline these 3 key challenges. First, we examine how the lack of solid evidence for add-ons is portrayed. Both the revamped rating system by the Human Fertilization and Embryology Authority, the HFEA, and the recommendations on add-ons published by the European Society of Human Reproduction and Embryology, ESHRE, confirm that most add-ons lack evidence of improved clinical outcomes. The ESHRE paper particularly notes of the 42 recommendations, none could be based on high quality evidence and only 4 could be based on moderate quality evidence, implying that 94% of the recommendations are supported only by low quality randomized controlled trials, observational data, professional experience, or consensus of the development group. While the debate is focused on evidence gaps, it's crucial to address how low quality or absent evidence impacts the information patients receive and complicates efforts to ensure reliable and transparent information. Poor evidence is often portrayed as simple uncertainty about benefits with little consideration of potential harm. This portrayal fuels hope market difficult to address as trading on potential requires no solid evidence. For those who are interested, I discuss this in more details in my upcoming open access book available in July. Next, we explore the quality and accuracy of information on fertility clinic website. While websites should not replace patient-clinician consultations, survey by the HFEA in 2018 and 2021 and research by the Competition and Market Authority, the CMA, in 2020 and 2022 show patients rely on this website for treatment information, including add-ons. Despite the guidelines introduced by the CMA in 2021, our recent article in Human Fertility reveals that 90% of websites claim or imply enhanced clinical outcome with time-lapse imaging, even though evidence now show it does not increase success rates. Additionally, 47% of the website lack a link to the HFEA rating system, and nearly a third do not provide cost information on time-lapse. These breaches in consumer law are perhaps unsurprising, given that an HFEA review in the summer of 2020 found 97% of clinic websites non-compliant with the HFEA Code of Practice. Unfortunately, at present, the HFEA has limited powers to protect patient interests in an increasingly commercialized sector. Finally, we discussed enhancing informed choice amidst the general lack of transparency about treatment cost. This is critical in the UK, where 74% of IVF cycles were self-funded in 2021, according to the HFEA. A 2023 survey by the Fertility Network UK reveals the significant negative impact of IVF costs on patient lives, with 92% of respondents reporting financial worries related to their treatment. Additionally, an article I co-authored with Josie Hamper highlights that patients were compelled to engage with a consumeristic model of healthcare even when they had access to publicly funded IVF cycles. Reliable data on actual patient expenses remains scarce, making it difficult to estimate the full extent of the problem. Our Human Fertility article shows that the cost of basic treatment as advertised on the website varies significantly across clinics, ranging from about £3,000 to over £7,000. However, Fertility Network's UK 2022 survey found that patients pay an average of £13,750 per cycle, with 12% of couples paying more than £30,000. To illustrate the concerns, here is a quote from a patient who contacted me during a survey on cost transparency and reliability of information I ran with the Fertility Network earlier this year, with the results set to be published in September. The quote reads, "I'm currently undergoing IVF and the costs for us have been absolutely insane. Luckily for us, it has worked on the first round and I'm currently pregnant, still early days, but I have had enormous issues with the never-ending charges and the complete lack of transparency around cost. We must have spent over 25K by now. I cannot imagine the stress it must cause for people who have to go through multiple rounds, sometimes without success. To address these challenges, the latest stage of the project have focused on generating collaborative proposals. These proposals are included in an interactive toolkit that you can download from the link on the slide and in the chat. The toolkit summarizes the existing guidelines, reports the project findings, and presents in-depth discussions of these proposals, highlighting concerns and potential barriers and offering key recommendations for effective implementation. The proposals are grouped around the main challenges they aim to address. The first 4 proposals specifically aim to foster evidence production. Firstly, creating a comprehensive research dataset would enhance transparency regarding how clinics use these treatments, potentially fostering peer support for the appropriate use of treatment add-ons, and ultimately strengthening trust within the field. The HFEA has pledged to consider collecting data on add-ons and to encourage voluntary submission as previously done to reduce multiple births. Other proposals in this group emphasize the ethical responsibility of both suppliers and clinics to redirect part of the profits generated by add-ons toward impartial national or international bodies to fund research on them. The second group of proposals aim to improve the quality of information on add-ons. One of these proposals addresses misinformation broadly by producing fact sheets to debunk misleading information proliferating on social media. The other proposals focus specifically on clinic websites and include establishing best practices such as assigning a staff member to ensure information is accurate and up to date, and creating information templates to facilitate website maintenance. The remaining proposals focus on active monitoring of this website, including implementing ad hoc audits, offering incentive or penalty for clinic based on information accuracy, and potentially creating an independent oversight body to monitor websites. The third group of proposals aim to support patient-informed choices. 3 of these proposals focus on enhancing cost transparency by adding detailed price information to existing patient database, such as the Fertility Mapper, and creating databases to compare the cost of fertility treatment and drugs across the clinics. Finally, the last proposal aims to update consent procedure to ensure they adequately cover information relevant to add-ons, including their potential risks, benefits, and alternatives. To conclude, I want to emphasize that patient empowerment in fertility care is an ongoing endeavor with multiple efforts aimed at improving informed decision-making, many of which will be discussed by the next speakers this evening. The proposals outlined in this project address the key needs and priority identified through this research, forging a comprehensive roadmap for action. However, they are subject to further evolution. Some proposals complement each other, while others may conflict due to differing approaches to addressing similar challenges. Feasibility of implementation depends on regulatory changes. For instance, effective website auditing by the HFEA necessitates the ability to enforce rewards and penalties. Future law reforms may impact the necessity of certain proposals. For instance, if the HFEA gains jurisdiction over protecting patient interests as consumers, an independent body to assess clinic website might become redundant. Overall, the findings of this project align with the HFEA call for law reform, particularly in safeguarding patient interest within the fertility market. Addressing conflict of interest underlying the challenges discussed in this project is crucial for developing a renewed regulatory framework capable of navigating an increasingly commercialized sector. Before leaving the stage to the next speaker, I'd like to give you the opportunity to share your views on these proposals by answering one question on Mentimeter. You can access this question either using the QR code or by going to menti.com and entering the code on the screen, 75210105, or you can click on the link available in the chat. We will share the results after the last speaker's presentation. Finally, I would like to thank the British Academy for funding this project and Queen Mary University for the additional financial support in designing the toolkit. And I want to express my gratitude to Marcin Smietana, the researcher who worked with me on this project, the PET team for their invaluable contributions, Research Retold for their support with research communication, and all the participants and members of the advisory board for their insight and support.
Our next speaker this evening has pre-recorded their presentation. And I think we were quite lucky to get the pre-record presentation because Alex Davies-Jones MP did it a while back, just before the general election was called. So I think if she'd left it a few days, we wouldn't have had her on the programme. But we thought it was good to get her involvement because of her as for an MP, she's probably been one of the most engaged on this issue for quite a while. And so Alex is the MP, or I think was the MP for Pontypridd in Wales, and she is the parliamentary candidate for that seat. She has criticised IVF add-ons very publicly and proposed a fertility treatment transparency bill in Parliament. It's a private member's bill. And she knows of what she speaks because Alex has been a fertility patient.
Hi, I'm Alex Davies-Jones. I'm the Labour MP for Pontypridd, and I have introduced a 10-minute rule bill to try and tackle the issue of IVF add-ons and also to create more transparency within the IVF process here in the UK. Now, since I was elected, I've been very open and honest about my own struggles with fertility. I've talked a lot about my journey through IVF and how I'm extremely lucky that my one round that was self-funded, because I was subject to the stepmom penalty, did result in my lovely little boy who's now 5 years old. But my route to having IVF treatment wasn't easy. It never is. Anyone who's been through this process, or if you've had a loved one who's been through this process, knows how emotional, physical and financially grueling the whole situation is. That's why, when I was elected to Parliament in 2019, I made it my mission to right the wrongs that I and so many others have faced when trying to access fertility treatment. Now, my 10-minute rule bill is focused on IVF add-ons. Now, we've all heard about these add-ons, whether that's embryo glue, scratching, extra testing that you can have done on your embryos, and all of this stuff sadly isn't backed up by the science and is being upsold by some unethical fertility clinics to people when they're in their most vulnerable state. Now, I wanted to do something about this, and I approached the government on trying to right this wrong, trying to create some more transparency about when clinics are being offered, when clinics are offering these treatments to patients, about how they should be honest about what is the percentage likelihood of them working, not just trying to upsell these basic treatments to people when they are in their most vulnerable state, when you're so desperate to have a baby that you will do anything and spend any amount of money just to give yourself a little bit more of a chance of it working. So I introduced this 10-minute rule bill into government, pushed government on trying to do something about it, and I'm pleased to say they have acted. They have introduced this traffic light system, and they are, with the HEFA, holding clinics accountable for what they're trying to sell to patients, because you want to be treated like a patient and not a customer. The other aspect of my 10-minute rule bill was focused on the data transparency about how many rounds of IVF are being funded by the NHS and how many are being funded privately. Because we all know that to access fertility treatment in the UK is sadly a postcode lottery. We need to end that. We need access to fertility treatment to be available for everyone who requires it. Currently, only half of all fertility treatment for under 35s are actually funded by the NHS. This is scandalous. It's not fair. It's inequitable, and we need to change it. So my 10-minute rule bill would have made data more transparent, so we know where this is happening, which health boards, which CCHs are funding this treatment, doing what the NICE guidelines say. And finally, I've been pushing for an update of the Act because we know it is out of date. It was great to see the government recently commit to allowing HIV positive patients to be able to donate sperm and gametes so that they can access fertility treatment. This was updating an Act that is way out of date, but sadly so much more needs to be done. The final thing I'm really keen on pushing is workplace acceptability. So getting that recognition in the workplace by your employer that you need fertility treatment, that you can have time off. So I'm working with my party, the Labour Party, to look to see what we can implement in an employment bill if we're elected and we form a government, because we know that needs to change. And finally, I want to talk about education. Because in school, all we are taught about is how not to get pregnant. That is the basic sex education that we get in school. We need to have a more robust curriculum that focuses on healthy relationships, that focuses on sex education, so that we can talk about this in the norm. So we can talk to women about what might happen if you can't get pregnant, and boys too. We need to be involving everybody in the conversation. So I hope that gives you a flavour of the things that I'm doing here in Parliament to try and push that agenda, to try and get the issue of fertility on the tables here of the policymakers and the legislators, the people where it really counts. But if you've got any ideas on what we should be focused on, please get in touch with me. That's what parliamentarians are all for. We love being lobbied by constituents, by organisations and by charities to talk about the issues that matter most to the people here in the UK. Thank you.
So following on from Alex, we have Dr. Rachel Gregoire. Rachel is Deputy Chair of the Association of Reproductive and Clinical Scientists, and she is Scientific Director of the Hewitt Fertility Centre up in Liverpool. Previously, she worked as an embryologist at Glasgow Royal Infirmary and at Ninewells Hospital in Dundee.
So as Sarah said, I'm the Chair-elect for ARCS currently, and I'm Scientific Director at the Hewitt Fertility Centres, and we offer NHS and self-funded care at the Hewitt Fertility Centres. Although I am part of ARCS and work at the Hewitt Fertility Centre, I do want to point out that these are my views and not the views of the Centre or of ARCS that I'm going to present today. So I was fortunate enough to be approached by Manuela and Sarah to join the key stakeholders group, the workshops, to pull together some ideas for the challenges that our patients face around additional treatments or add-ons. And just to give I know Manuela has gone over this earlier on, but I just wanted to focus on a bit of the background of where we got to. So it was a group of us together, I think on 4 workshops, where we identified the key challenges that patients are facing. And that was quite challenging for us because we kept looking at actually the ways we could help and actually fix these challenges, but we focused on the challenges, then pulled together some proposals on how we could address them, and then finally looked at all of the proposals that Manuela had pulled together for us and looked at how we could prioritise these and whether we could actually feasibly implement these proposals. So there were 6 key challenges under 3 main themes. And within those key challenges, we came up with 14 proposals, hopefully to address these challenges. And we then considered which ones we felt were of a priority. And I have to say, on the work that Manuela and Pet have done, massive thanks and well done for pulling this together. It was great to be part of the workshops, and it's such an important piece of work. So well done to everybody for pulling this together. So I was asked to come and give a clinic's perspective on the proposals that were put together in these workshops. And as I said, the challenges were covering 3 main themes, which Manuela touched on earlier on, around really looking at how we can improve the evidence for add-ons, how we can improve quality of information about the different add-ons and the risks and potential benefits, and how we can support patients in making informed choices. So I was asked to cover 2 proposals out of the 14 today, but I may have sneaked in a couple more. As long as I stick to my time, hopefully I'll be all right. So the first proposal was around, if we think about the first theme, around producing more evidence for add-ons. And one of the proposals was to create a comprehensive database. And I've chosen this one because I feel quite strongly, and I'm not going to look at Rachel Cutting from the HFEA on this one on the panel, is that we have one. All clinics have to, by regulation, we have to report to the HFEA on every treatment cycle that we perform. Each treatment cycle is, we have to submit data 5 times throughout the cycle if somebody is successful in treatment. So we provide a lot of data. And that data is held, obviously, on the HFEA's database. And it's a massive and fabulous resource for all of us. And as I said, each cycle is reported separately, and the fate of every egg and embryo is reported via these reporting events to the HFEA. And the addition of 1 or 2 mandatory tick boxes on these data reporting events around add-ons that were used for that embryo could really impact on the data gathering. And yes, it would be retrospective data. Yes, it would be meaning somebody would have to analyse that data, but it would mean that at least that data within the UK would be held in one central place, that every time we transferred an embryo in a cycle, that time-lapse was used, you know, our time-lapse incubators, but maybe time-lapse was used, but we didn't use what was known as an embryo selection model. Maybe the embryo was biopsied and genetically tested. Maybe sperm was selected to produce that embryo, or maybe embryo glue, as we mentioned earlier. These are just some of the examples that just a simple tick box would mean that that data would sit there, and a freedom of information request could access that data, be able to analyse that data and look at the success rates. So I think this is a really feasible option that we could look at to really improve the evidence that we have in our hands in the UK. The second proposal that I wanted to cover today was around, we talked about the quality of information that's provided to our patients. And we heard earlier from Alex, and it must be so frustrating and so confusing for our patients. But one of those things was around fact sheets, that why could we not just simply produce a neutral group of fact sheets to debunk all this information or this misinformation that's provided on social media and on different websites. And I'm pleased, as part of ARCS, to say that ARCS and the British Fertility Society are working on a shared access area that will contain patient information leaflets that will be accessible to all. And that will cover lots of different sort of treatments and add-ons and so on, that patients coming soon will be accessible for people to and within that, based on the work that we did within the workshops, we actually thought what would be really useful was to do an additional leaflet around actually some of the common myths that are shown on social media, on websites, and maybe do a sort of fertility myths debunked leaflet or something to add to that group. So that's hopefully in the pipeline coming soon. The third proposal I wanted to discuss was around we suggested that we could really do with dedicated staff to improve clinic websites and to improve the quality information that's provided to our patients. And this caused a little bit of real heated debate within the workshops, because insisting that clinics identify staff that they are responsible for improving clinic websites will be extremely difficult to enforce, and it'll be very difficult to measure. And clinics already have a person that is responsible for their website, and that is their HFEA person responsible. The person responsible is already responsible to the HFEA for what information is provided to patients. Clinics' advertising budgets and their budgets for social media for websites vary. Working from an NHS centre, I sit in envy when I see social media posts or websites of some of our private colleagues and private clinics. It would be fantastic to have that sort of budget, but we simply don't have it. They are very different. So I think this would be a really difficult proposal to really put together and really sort of show how much this could improve the quality information. The fourth proposal was around improving quality of information again, but looking at how we can regularly audit websites. And again, I would argue that this already happens. Every clinic is inspected every 2 years by the HFEA. There are website tools available, website audit tools, I should say, available that already exist, that have been used by clinics pre-inspection before. But those audit tools do focus on data. They focus on clinical outcome data and a real specific details around success rates and how websites demonstrate their success rates. And there isn't really a focus on the quality of the information, and no one looks or has looked certainly at our website or contacted us about our website around sort of big claims, big claims that clinics can make, that using time lapse can double your success rate, or so on and so on. And there isn't a focus on that. And I think we could look at how we have to provide evidence of patient information and provision of information to the HFEA for an inspection. That could also include the website as well. So I think there is some extra work that could be done around that. A great example of how websites are reviewed is UCAS. UCAS assess diagnostic laboratories, and they specifically look at user information on websites and do that annually. So that is something that is done, but they only focus on diagnostic services rather than treatment services. The final proposal I want to hopefully have time to talk about is a database comparing treatment costs. And this would be wonderful. I know Manuela touched on its fertility mapper. It is confusing. And it's confusing for somebody who's looking from a clinic's perspective and looking to see what we charge our self-funding patients compared to another clinic, because you cannot decipher what is included in a standard cycle. And that would need to be the first thing that clinics need to do, is to work together to really agree on what is classed as a standard cycle and what should be included in a standard cycle. And also that what would then be added, could be or would be added on in that clinic above a standard cycle. There are some things that are classed as add-ons and simply should absolutely not be an add-on. An example of that is extended embryo culture, or potentially a type of incubator that somebody uses. This should not be classed as an add-on. It should be part of that standard treatment cycle. So clinics would really need to work together to make sure that this database, to help patients make informed choices looking at costs, that it was clear and patients it was usable for our patients. And just finally, if I've got time, I do want to just acknowledge that clinics are in the majority extremely good and are trying the best for their patients and are trying to offer treatments that they feel may hopefully give a patient a glimmer of hope. And I just wanted to demonstrate, this is 4 of our young scientists who you can't see what they've written on here, but this was Healthcare Science Week. And they were showing why they were proud to be an embryologist. And on what they've written there is to offer a really high standard of care and to make hopefully changes to people's lives. So clinics really are there to try and offer the best they can to patients. It just does appear that there is a lot of confusion and misinformation that is also there. And the middle image there is us performing our first PICSI treatment, which is an add-on. And again, this took 12 months of evidence gathering, of demonstrations to our colleagues that we felt this was the best thing to do, a real team effort, presenting it to the trust that are actually really excited about the possibility of reducing miscarriage. And we take it seriously. Implementing an additional treatment is taken seriously, and took, this one in particular was 12 months in the making to get to the point of offering patients at a cost, but to cover the costs and not to make a profit.
Now, our next speaker is another Rachel. And you'll spot some similarities between these Rachels. Rachel Cutting. Rachel Cutting is Director of Compliance and Information at the Human Fertilisation and Embryology Authority, the HFEA. She was previously a clinical embryologist and chair of the Association of Clinical Embryologists, which is now part of ARCS. So it's quite nice that Rachel is chair-elect. The other Rachel, rather, is chair-elect. So we can see some parallels there. But Rachel Cutting is an embryologist for a very long time up in Sheffield, extremely respected in the sector for her work in that area.
So thank you very much for the presentations, and especially Manuela and all her team that's been involved in the project. I know some HFEA members have also been involved in the project for the hard work putting such a good report together. But what I wanted to start with saying actually is that the HFEA has always had the aim to build a consensus among professionals and patient groups about the way add-ons are offered in clinics. We've always wanted to improve the quality of the information available on the evidence-based and the evidence that's presented to patients. And that leads to promoting the ethical use of add-ons by providing guidance for clinics and through what we can do on inspection. I'm sure many of you have looked at the HFEA website and looked at the new ratings that we do for add-ons. Of course, quite a few years ago, we produced our traffic light, which was a simple red, amber, green system. But over the years, and in 2022, we launched our new system, which provides really in-depth and more information about the add-ons and looking at the evidence that's there to work out what rating should be given to each add-on. And we also now look not only at the chance of it improving the live birth rate, but we will look at the effect of an add-on has on specific patient populations and also outcomes such as the miscarriage rate or risk of OHSS. All this information can be found on the HFEA website. We have dedicated pages to add-ons. Each add-on is described for what it is, how it can be used, what the evidence is, what the rating is, and when it could be considered useful in the different populations that I've said here. So, you know, we welcome ARC's BFS working to provide perhaps, you know, fact sheets that complement our information on our website and gives more information for patients and clinics to use. We also worked with 8 professional and patient bodies to produce our consensus statement about the use of add-ons, and that can be accessed through our website as well. So we welcome the toolkit because we have a clear agreement that we want to improve the quality of information for patients and work towards this ethical use of add-ons. And of course, we can ensure as a regulator that there is improvement for patients, but there is that problem that we need better powers to regulate on the use of add-ons. So as Manuela said earlier, we have limited powers over the introduction of add-ons. We do have some powers about the information that clinics must provide to patients so they can make informed choice and consent properly. But what we specifically lack powers on is about marketing, clinic pricing, but we have worked with the CMA and ASA to improve on that. And Rachel said about earlier on in her talk about what is just a standard IVF cycle, and the CMA have been working on that, and that's quite challenging to get agreement amongst the sector on. Actually, it sounds as if it would be quite simple, but it really has been a challenge for them for that work to continue. So what mandatory requirements do we have when we're looking about the regulation of add-ons? Well, there's 2 licence conditions that I can pinpoint to this evening. One is T2, that suitable practices must be used in the course of activities authorised by the licence. Now, suitable practices is quite a big way of putting it, isn't it? And it's quite a grey area. So sometimes it's quite difficult to really define what a suitable practice is. We really need that to be better defined and more better described, I suppose. We've also got T58, which means that anybody providing gametes for treatment and having treatment must be provided with information about the nature of the treatment, its consequences, risks, etc., if they're going to be performed. So it's these 2 things that we can definitely look at on inspection. We've also got the guidance in the Code of Practice, and this sets out how we believe that clinics can work in a way that meets the mandatory requirements, but this is guidance. So we set out in the Code of Practice, and this is in Guidance Note 4, 4.7 to 4.9, and it says before treatment starts, information must be given including about the add-ons that you're offering, and we do state that there should be reference to the HFEA add-ons information, so a link to the HFEA website. And that's something that we do check on inspection. As Rachel said, we have a HFEA audit tool, and that's one of the things we check. We ask for clinics to provide information on the way and why the add-on is being offered. Why might it actually help you as an individual? Why might it help you improve your chance of pregnancy or reduce your chance of miscarriage? And then we also expect that the clinic would discuss immediate and any long-term risks of the treatment and the add-ons as well. On inspection, we can follow up on the licence conditions, and we can follow up on the guidance that we provide as well. And we do ask PRs to complete the add-on audit tool pre-inspection, which will cover how add-ons are offered, what information's provided, what's on the website, and we review that as part of our desk-based assessment as part of the inspection. And we do look at clinics' websites. We look at them prior to inspection, as Rachel said, every 2 years, and we do check and we do make recommendations for change, but we can't scan that website 24 hours a day to look at the information that's there. Following on from that desk-based assessment and the add-on tool audit that we do, we will discuss on site with the PR and clinic staff to ensure that information being provided is appropriate. And we will, in specific cases, look at patient information and consent forms. So, for example, if calcium ionophore is being added, or in biopsies specifically for PGTA. But there is concerns, like I said earlier. We have limited powers. The Act is 30 years old. There weren't add-ons. I started in 1994, and it was very simple, that you just grew the embryos to day 2 and you put them back. So things have changed dramatically over the years. So what we want to do, and I'm sure many of you here have looked at our work, looked at our proposals on the website, is that we really have recommended recently that the Act should be revised to include a focus on patient protection, as well as, of course, the embryo and gametes. So where are we now? We have a commitment to continue to promote our add-ons information and to ensure patients get the right information. We will continue to review through our scientific committee, look at new evidence that's there, any new papers that come out, or good practice recommendations to ensure that our information stays up to date. We will consider the voluntary collection of add-ons. As Rachel said, the HFEA has the longest standing database in the world. It has every treatment cycle that's in the UK with outcomes on through IVF and donor insemination. So it is such a valuable point of information. Whilst you think it would be quite simple to add add-ons, when we did the information for quality project quite a few years ago, there was resistance from the sector about the burden of having to constantly provide information to the HFEA. So the data set was actually stripped back for when we started work on PRISM. So that we'd have to work on the sector and ask and consult on that to see what agreement we had and how we could move forward with that. And of course, we will continue to promote our law reform proposals and hope that we do get the improvement there for patients and clinics in the future. Thank you.
Thank you very much, Rachel, for that great overview from the regulatory perspective, and what's done, what may be done, what could potentially be done better in the future, all depending. So our final speaker this evening is going to be thinking about the issues from the patient perspective. And it's really super to have Kate Bryan as our final speaker in the week that the Fertility Alliance, which is a new patient charity, has launched. So really great. But you may think, gosh, I know that name, Kate Bryan, and that is because Kate has been in the fertility sector for a number of years now. She has, as well as co-founding the Fertility Alliance, she is editor of the journal Fertility Counselling, and she was a member of the Human Fertilisation and Embryology Authority. And in addition to that, she was the Women's Voices lead at the Royal College of Obstetricians and Gynecologists. And she has authored a number of books, including Precious Babies, The Complete Guide to IVF, Complete Guide to Female Fertility and In Pursuit of Parenthood. So I don't know if she's got another book in the pipeline or whether that's that's something that she's thinking never again. But over to you now, Kate. I'm very much looking forward to hearing your perspectives on how we can try and move this forward for patients.
Thank you so much, Sarah, and thanks to PET for inviting me to join the event this evening. It's really lovely to be here. And I also particularly wanted to thank Manuela and all of the team for this really important work. I think it's really good to hear the views of the panel as well about how we might be able to improve things. I have to say it was actually my Fertility Alliance colleague, Anya Sizer, who was involved in this project for the charity. And sadly, she couldn't be here this evening, so I'm here on her behalf. And I hope that I'll cover most of what she would have wanted to say, speaking from a patient advocate perspective. And also apologies for the fact that I'm not using slides. Things tend to go wrong when I do them live, so I thought I'd spare you that. So how best to inform patients is a subject we're really interested in at the Fertility Alliance, and one of our key reasons for existing is around the provision of evidence-based information. You know, there aren't necessarily rights and wrongs when it comes to these things, but what is important is that patients are making informed choices. And the Building Bridges project really has the potential to be very helpful for fertility patients. So the first area that I wanted to focus on was around the provision of information and the proposals to improve the quality of information, and particularly with the production of fact sheets. And it's really not very easy being a fertility patient today because there's never been more information available, but actually it's never been harder to make sense of it all. And when I was at the RCOG, we did a very interesting survey about information, which found that most people found information about fertility confusing. They weren't sure it was impartial, and they often felt that they were being told completely contradictory things. And I have to say that happens all the time. I've seen so many patients who end up confused. They've been to one clinic where they were told one thing and another clinic where they were told something completely else. So how are they meant to know who to believe? And when it comes to add-ons, that's one of the most difficult things of all. And I think when thinking about this, it's important to go back to the perspective of the individual patient going through a treatment cycle, which Alice Davies-Jones explained earlier. And at that point, you're completely focused on what you can do to have a successful outcome. And I think most patients would actually do pretty much anything if they believed it would make a difference. That's why so many people are eating pineapple core and wearing fluffy socks to keep their uterus warm. For us as a charity, what's really important is they're making informed decisions based on evidence. And we know there is some existing guidance, but do all patients use it? I think there's sometimes a level of mistrust around official information. I've had patients tell me that the HFEA information and ratings about add-ons are out of date or that they don't include key research. And also, I can't tell you how many times patients have come to groups saying that they're using X or Y add-on because the clinic told me to, rather than because the clinic gave me all the information I needed. I spent some time thinking about it, and then I took an informed decision based on that information to use X or Y. And maybe clinics are telling them to use add-ons, but maybe actually they aren't telling them that at all. If, as a clinician, you say to your patient, we don't have evidence, but this may help improve outcomes, you may think you're being honest, open, balanced, you're saying there's no evidence, you're saying this may improve outcomes, and that's all quite true. But the message the patient on the other side of your desk is hearing may be something else entirely, because we don't have the evidence often translates to a patient as we don't have the evidence yet. It suggests this might be something quite cutting edge, quite exciting. And I don't think patients usually expect that more evidence is actually going to show that a treatment doesn't work. It's just not proven yet. And if you say this may help improve outcomes, that often translates as it's likely to improve outcomes. After all, if you're talking to a doctor, they wouldn't be suggesting something if it didn't make a difference. And as a patient, something that makes a difference is the difference between treatment being successful and not being successful. So, for example, there's a type of coaching that claims to double IVF success rates. And there's a type of yoga which apparently increases your chances of IVF success by 20%. So if coaching and yoga can do this, then an additional treatment offered in a licensed fertility clinic by a qualified doctor, which may potentially increase your success rate, is going to do at least as well as the coaching and yoga, isn't it? Well, I was quite surprised to discover that for an add-on to be shown to work, it might actually only need to add a couple of percentage points to the chances of success. And I don't think that's what most patients are thinking of when they think an add-on's been shown to work. So evidence-based information in fact sheets, including all of this, will be really useful. And it's great to know that these are already on their way. They need to be simple, they need to be easy to understand, and it will be useful to have links for more information for people who actually want it. They should also be social media friendly versions of the fact sheets, which would help to make them more accessible. It's going to be really helpful, but it isn't just about producing the information, it's also about making sure that patients actually get it. If everyone in every clinic was giving patients the same information, if everyone actually got that information, we'd go a long way to improving things, not just for patients, but also for professionals. And that's what we need to see. I also wanted to address the point around cost too, and Rachel's already covered the idea of a database for costs, but I think it could be incredibly useful. We know that patients often look at the headline costs when they're looking at websites, clinic websites. And at Fertility Alliance, we've just done a patient survey, and almost a third of the respondents who'd had private treatment said that it actually cost them more than they'd expected. It wasn't always clear to them what was included and what wasn't. And many said they were charged thousands more than they'd anticipated. One patient actually reported paying an extra £500 just for blood tests alone. And I don't think patients always realise quite how much discrepancy there can be between the cost of add-ons at one clinic and another. And patients knowing how much other patients are paying, being able to compare the costs at one clinic and another would be so helpful. I actually tried to do an online search of the costs for a particular add-on recently, and I found it completely impossible. Some clinics had it as part of their standard IVF cycle. Most didn't, but there weren't always clear breakdowns of the extra costs of different things. One clinic wanted my email address, name and email address, if I wanted to find out the costs. Our survey showed that a majority of patients were having to borrow to fund treatment, from family, taking out loans, using credit cards. And I don't think clinics always appreciate the financial struggles many patients face. So clarity on costs, so they know what they're getting into at the outset, would make all the difference. The final area I wanted to address was peer support for decision making. And I know that the Building Bridges team have thought about this in relation to peer support from one professional to another to encourage best practice. But as a former patient, peer support means something a bit different. And there's actually another side of it, which is specifically for patients, relating to the peer support we give one another on this subject. And interestingly, now patients often seem to listen to one another almost as much as they listen to experts. So often in this post-truth era, doing your own research online can be seen as just as valid as years of training and experience. And so there's an opportunity for peer support from one patient to another to make a real difference. The loudest voices at the moment are often the people who've paid for a lot of extra things and want to tell everyone else about it. You don't need to spend long in spaces with patients to understand how big an influence it can have. And let's face it, if you've spent thousands of pounds on add-ons and you have a successful outcome, you're likely to think the add-ons played a role, because no one wants to think that they remortgaged their home or didn't have a single holiday for 3 years or took out a loan for something that didn't make any difference. And then there's this idea about add-ons being part of tailored treatment, which is better than normal treatment because it's just for you. But of course, in reality, a clinic might be offering exactly the same additional treatments to every patient. So all of that makes it very hard for people who are just having the standard IVF package offered by their clinic, which may or may not include some add-ons as standard. If you aren't paying for anything else, there's sometimes a sense that you might not be doing all you could, that you might not be trying hard enough. I've spoken to a few patients over the years who feel very anxious about not having add-ons, who worry that it might not be okay just to have IVF or ICSI without paying for anything else. And there's sometimes a sense of almost needing to give them permission to make this decision, of saying, yes, this is perfectly rational. So maybe the way to approach this is to try to empower some of those patients, try to amplify those voices to help them to support one another. And we need to make sure that people understand it's okay just to have the clinic package your clinic offers, and that not paying for add-ons doesn't mean that you're any less dedicated to your treatment working. We need to help them know it's okay to say no, and to encourage them to understand that making your own decision can be making a decision not to do something. It's fine to choose that. So what we need is clear information, the same information shared with everyone, which is honest, transparent and clear, and then encouragement that the decision is yours and yours alone to make. And as a final point, I can't tell you how many times clinic staff had told me that their patients want add-ons, that they might go somewhere else if they didn't offer them. So maybe clinics need to show that same bravery that some of their patients are showing. If you aren't convinced that something's really making a difference, then be honest with patients. And if you think something really works, if you can see it's making a huge difference to all your patients, then should you consider whether it's part of your standard offer? Clarity and transparency are vital, and it's better for everyone involved if patients are able to make truly informed decisions about their treatment and about any add-ons.
Thank you very much, Kate. That was really powerful, and just so many points that you made resonated with what I've heard over the years. And I've recently heard of someone saying they had to pay a £500 for an admin fee because they were using donor sperm, that they, that was just for the paperwork. But so it seems, something again that they were not aware of at the outset of their treatment, shall we say. And I think you're absolutely right that people seem to be getting, because I've been around a long time like you, more and more likely to listen to other patients and to be guided by that than by, say, a fact sheet that the BFS and ARCs may produce, for example, or something that the HFEA have on their website, because it's just, I don't know whether it's that human connection or something. I don't know how these things work, but it's but it does seem to have taken a hold. Now, Manuela, do you have the results of the Mentimeter for us?
So it looks like the fact sheet are the first choice for many of the people who voted, and then the creation of the database for cost, followed by the creation of a comprehensive research dataset about the use of add-ons.
Great. And then and then we've got in at number 6, the offer incentive or penalties for information accuracy. Oh, really interesting. Do any of the panel want to come up to talk about any of those results, if they're surprised or pleased? Perhaps it's pleasing for ARCs if they're doing some work on this to do some fact sheets. See, they're welcome.
Yeah, I'm not surprised, but also I'm really, really happy with that. I think that's how I would agree. I think some of the things are going to be more tricky to do, and they're the ones that have scored lower, so that's quite positive for me, I think.
Yeah, you'll be pleased to see only one for assigned staff to improve clinic websites.
I'm keeping silent about that one. Just have a smug face.
Anybody else? Kate, do you want to come in on any of those?
I'm really pleased that the database to compare costs is come out so high, actually, because I think that's one of the things that patients often find really difficult at the moment is comparing costs, and I think more transparency on that would be really useful.
I don't know about you, Kate, but I've come across people who are, they're creating quite complicated spreadsheets to try and get a handle on this for themselves, and so they can try and compare between clinics. But I think, as you said, unless you keep asking the questions of the clinics, you don't get the information isn't there on the website for you to have it all to your fingertips. Rachel, Rachel Cutting, did you want to come in?
I was going to say, I think it highlights that, that it would be useful to ensure that clinics do signpost to HFEA website, because there is a lot of information about the misinformation about add-ons already that's on the HFEA website about the add-ons.
Somebody says, doesn't 4.11, the code of practice, not require clinics to provide a costed personal treatment plan but to patients, including the cost of treatment, which is, I wouldn't have known the provision, but I thought that, say, Rachel.
Yeah, there is. There is code of practice guidance, it is guidance that we do expect clinics to provide a costed treatment plan, and they are looked at on inspection. And certainly I was asked to show them when I was PR in my clinic, and we developed them that showed exactly what the treatment cost and the options. We didn't have add-ons, but we did put other things on there, like if more drugs were needed, or if other things like what cost of freezing cost, for example. But certainly inspectors do look at that on inspection.
Can I jump in, Sarah?
Yes.
Okay. I think it's because we have them, but I think potentially the concern would be that the patient is almost already in. So I think a patient is wanting, or maybe using that to select the clinic. I don't know if that's as important as other aspects for the patient, but if they've already selected a patient based on a non-personalized costing plan, and then find that actually things are added on, they've already paid for consultation, expensive tests to get that treatment plan, and then find there's a lot more cost to it, they're almost already spent money on something that I'm assuming that might be quite a large risk for patients. I don't know if Kate feels the same.
Yeah, I'd agree with that. I think that was one of the things that came out when the CMA did their work as well, that once people had kind of made that commitment of starting to pay for things, then they almost felt quite reluctant to move, probably understandably, because they've already made a financial commitment as well as anything else. I think it's quite an interesting question, actually, whether there's a way of getting around that. And I do think that earlier information would be really helpful. The clearer you can make it. And obviously, there are things that are going to be difficult to assess. You don't know exactly what level of drug someone's going to need and how much that's going to cost. But I think giving people a much better broad idea of how much the clinic costs on average in that treatment centre, rather than just these headline prices that you see on a lot of clinic websites that don't really bear much relation to how much people often end up paying.
Okay, so I'm going to go to it's a sort of there's a comment really from Rosanna Cawthorne, who says, for Rachel Gregoire, fantastic presentation, thank you. Could I suggest that the fertility myths leaflet considers different cultural backgrounds, religions, and ethnic groups? Is that something that you're able to accommodate in?
Yes, accessibility wise, that's already in process or in progress. But I think that's a great idea, and I think Jackson, who's the current chair of ARCS, is really heavily involved in the patient information leaflets, and he's very, very keen that we ensure that different cultures, religions, myths, all of this thing is included. So yes, it's a great idea, and I'll certainly take it back to ARCS that we make sure that's covered in as part of that.
And yes, Rosanna, I can echo what Rachel says, actually, because Jackson did actually make that specific point in one of the workshops. Although it's Chatham House rule, and I shouldn't say that, I don't think he'll mind because it's positive. But no, it's certainly something that came across quite strongly. But also another point that Rosanna makes while I'm sort of with her, and that is that she says people aren't just listening to other patients generally, which has been the case since Mumsnet chat rooms, but social media influencers, and those people may be in paid partnerships. And I think that is something that's be quite hard to unpick. Can it, Kate? What do you think about that?
Yeah, I'd actually really agree with what Rosanna said. I mean, I think it's a very difficult thing sometimes to work out quite where some social media influencers are getting information from and what evidence base is around that information that's being given. And I think it's all this stuff that makes it really much harder for patients. And it's what I said earlier about, there is just so much information out there now, but there's never been more misinformation, and it's never been harder to make sense of it. And I think anything we can do to give everyone the same information from reliable sources is going to be incredibly helpful.
Manuela, is your research throwing up any sort of impact from social media influences?
We haven't looked specifically at social media yet, but we haven't programmed to look at that as a next step, because it clearly came up during the project as part of the narrative, of the general narrative, and there is no current study to see what sort of myths are those that are most commonly shared and what sort of narrative are supporting some add-ons at least.
Okay, I'm going to go to the next question, which is someone who's chosen to be anonymous, and they say, given giving more patient power sounds great, but will it not be stressful for patients to have to challenge health professionals offering the add-ons? Where else in healthcare does this happen? So, who wants to go first on that one? Well, let's go to Kate first.
I don't think we should be putting patients in a position where they need to challenge health professionals. I think health professionals need to take responsibility themselves. I think it's really wrong to think that patients should have to do that. It's really stressful going through fertility treatment in the first place. And I don't think we should be expecting patients to be challenging doctors about what they're being offered. As the question says, it doesn't happen in other areas of healthcare, and I don't think it should be happening here. I think we need more honesty and more openness and more transparency, and I think everyone needs to be giving patients the same information so that they all know they're getting the same information. They don't need to make individual challenges about, are you telling me the truth? Are you sure this is correct? Do you have any? I think it's particularly difficult for patients to ask doctors whether they actually have any commercial interests in a particular add-on, and I'm not really sure that it's fair to put that onus onto patients.
It would make it a very different relationship that you're having if you're sitting in that consulting room when you're already struggling with information overload. And also, let's face it, you're always wanting to try and make the medical team like you. So it's in the sort of ambition that you will be treated a little better. Because they'll see that you are such a lovely, worthy person and you're so desperate, and they'll want to help you even more than the person you've just been looking at in the waiting room. So I can really see that would be a massive challenge, for people, and incredibly stressful. But I think it's one thing, isn't it? Thinking about how we standardize information on websites, but once you're in that room, there's no way really of regulating what's said, is there? Rachel, there's not really much we can do, is there, even the HFEA, because you can't read every website every day, let alone sit in, even one or two consultations.
Yeah, exactly. We can assess a website on the day of inspection. We can look at it prior to inspection, but we can't continually monitor it. Sometimes we do get it pointed out through a patient inquiry or a complaint, and we would address it then, but we can't constantly keep monitoring it.
So anybody else want to come in that, or I will move on? Yeah, Rachel,
it was
Gregoire.
just a thought about thinking about the comment, the question that was made. I think if we soften that a little bit and thinking of, in a consultation room, a clinician clearly believing that an add-on could help a patient, and a patient feeling that, well, I was told to be cautious about add-ons. I know I should be cautious. I should ask about the evidence. I should ask about that. Must be still extremely difficult. It's not necessarily a challenge, but it's, as we said, making an informed choice would be asking difficult questions. And it's not us putting them in a position that they have to challenge, but that will still be very stressful for a patient, I'm assuming. So I'm just wondering whether that question's a bit more gentle than that, and actually how do we stop that happening? And I don't know the answer. I'm just thinking of how difficult that must be for the patient. Because thinking about the clinician, sorry Sarah, just when we had the workshops, listening to the clinicians that were in the workshops, they're sat in front of the patient and they are desperately trying to find a way who somebody's treatment hasn't worked previously, and trying to find something that may give them the extra chance. They're in a difficult position as well, aren't they? I'm not coming up with any answers here, sorry.
No, I suppose I was thinking about perhaps that's another resource, is something for patients to, how to ask the killer question in a nice way, to put it bluntly.
What questions to ask?
It's not confrontational, but is just sort of to, whether it's, I think something perhaps even as simple, it's when Kate was talking, actually, some patients won't realize how long an add-on's actually been around. You might think something is new, funky and cutting edge, but actually it's been around for 20, people have been talking about this for 20 years, and it's still not part of mainstream treatment, or even mainstream treatment in a certain cohort of patients, if that makes sense. So I think there is perhaps something there. But that brings me on something that you just said, Rachel Gregoire, to something from Hannah Horn-Robinson, who says, what has been done or discussed about differentiating information based on where a patient is in their infertility journey, i.e. someone exploring IVF for the first time needs very different kind of information than someone on their 5th cycle further down the sort of experimental rabbit hole. So we can sort of, it is a different conversation then, isn't it? If you've been having, you've done 3 standard cycles, and then what next? And then you've added something else in, or you've done something slightly differently, different drugs or what have you. So what do you think to that, Rachel Gregoire first, and then perhaps Kate? And
that's a hard one, because I think I would hope that patients were just offered treatment, the standard treatment, and no additional types of treatments would be suggested unless there was something that they felt that was really within this patient's medical history that would need it. But I don't know. I can only talk personally. We have our standard cycle information very separate to our additional treatments information. So we would suggest to patients, scan that QR code, that will take you to your treatment information. But if we're offering you something else, this is where you'll find it. I don't know. It has to be kept separate, very much so. The standard treatment and what it includes needs to be very clear, and needs to include all of the risks of just IVF in general. I don't know if I have the answer to that. That's a difficult one, but it needs to be kept separate and only provided at that point, I guess, where something additional is considered for the patient.
Anybody else want to come in on that one? Kate, sorry.
Can I just say, I think really it's the patient decision that might be different at a different stage of the journey. So you may consider different things at different stages of your journey of where you are, but I don't actually think that the evidence is any different. It's the same evidence that you should be giving wherever someone is. So in theory, it shouldn't really make any difference.
Rachel Cutting, I think, I thought you wanted to say something else.
Yeah, thank you. I was just going to say that, exactly following on from Kate, actually, is that if you look at the evidence and you look at the HFEA website, if you do decide to use an add-on and it's because you're on your 5th cycle, there should be some evidence there to why that add-on is being offered. Now, if it's recurrent miscarriage and there's been some tests done that's shown that one of the add-ons might make a difference, then that's very different to just saying that, if there's no evidence, but just try again with it. There's got to be a reason why it's being offered, and there's got to be some evidence behind it.
Okay, so then I've got 2 questions from Ghulam Bahadur. So he says, nice talk, Rachel. You can both take that one. Commercial reasons is such a driving force for add-ons. How can we trust the data being collected to justify the use of an add-on? And then he asked another question, but I think sort of bundled in together really. Unless there is a good RCT, the bias to promote an add-on is there. So I think we'll go to Rachel Gregoire first.
Yes, the quality of the data is only as good as the quality of the data shared. And if we take, for example, the thought of a central database collecting evidence of add-ons, it's the same quality of data as we provide currently to the HFEA, for example. There will be quality issues. Can we trust it? I think we can only trust it as much as we currently trust the data that's shared with the HFEA. So I don't see why there would be reason for someone to not add that information when they enter the data. The good quality RCT, yes, but it's just it is such a difficult task to get a funded RCT off the ground, and clinics do their best to look at their own data to evidence whether they feel something is working or not. I know if we had Jack, who was on the workshops with us, would strongly disagree with me there, but this is all that is in the realms of possibility for a clinic who are working clinically and are not researchers. So yes, the data will be messy, but we can only trust it as much as we can trust the HFEA's data now.
Anybody else want to come in on that one? Rachel Cutting and then Manuela.
I was just going to say again, going back to the process of how we rate our add-ons is a very robust process, which was agreed by the authority, and it's used by the scientific committee that we have, that we go through an evidence review, the evidence is graded, and then that helps us inform the overall rating for that. So that's quite a robust practice that we do. If we are collecting data in the future, we have a new database that's taken several years to develop, which we are nearly there now, called PRISM, which the quality of the data coming into that and the error rate is very low, and the data has to be validated. So we know that the cycle data coming into us, which is a mandatory requirement in law for clinics to record that with us, we do several verification and validation. There's error, there's different errors that pop up that the clinics have to collect. So we know that on the cycle level, we should be getting accurate data. So if in the future we did add extra fields onto it, we know as long as that's being submitted correctly by the centre, which again, we go out and do audits to check that that's being done, we would get accurate data.
Manuela, did you want to come in?
Yes, I just wanted to add that while during the workshop, there was a lot of discussion in terms of the ability of a comprehensive data set of producing evidence in the sense of RCT, which wouldn't be the case because it's not going to be an RCT. There was a certain level of agreement of the ability of such an instrument to actually give an idea of how many add-ons are used, where is there a difference. For many people, there was no idea if in the next door clinic they're using the same sort of rules. Is he offered to the same percentage of people? Is he offered to certain type of patient or not? We don't know if some clinics are offering some add-ons to 80% of their patient or 10%, and it becomes very difficult to have a conversation on whether these are offered only in some circumstances, for instance, to patients who are on a very high number of cycles, or if this is part of the additional offer that you start with. It's very hard to have a conversation where the basic data on how the use of add-on is distributed and where is not there. So even if he's not able to produce evidence in terms of the effectiveness of the add-ons, it would actually give a very clear view of how many, where, how, is there a difference, and so on and so forth.
Yes, I think it could be a question of, not making perfection the enemy of the good, but if we had a broad overview of what was going on and that people could see even a rough trend, we would be in a better position than we are now, I think, in terms of having to take a look at it. And then I suppose it would be a question of drilling down and researchers looking at that in different age bands, etc., and to see where they were applied and if there were any difference in the outcomes. And as Gulam says, it is a sort of follow-up question that, about, which I think you've answered really, that this data would be robust enough to do that 10 years down the line. Because of the systems and checks that are already in place. Okay, so this is a yes or no question for you, Rachel. Gregoire, are the results of your 12-month study going to be published in a peer-reviewed journal? Because this has to be the way forward.
I may have been I may have confused it with what I'd said earlier. We haven't done a study. This was 12 months of development of sort of like an internal process of implementing a new test. So the 12 months, it wasn't a study as such, it was us validating and implementing an add-on, and that's, I was just demonstrating how long we took to do that. But on the back of that, though, we will be evaluating the outcomes against sort of previous work. It's not an RCT. It may not be accepted for publication, but we would absolutely be analysing the data to see if it is improving anything for any particular group of patients, and we would share that. And obviously, if we found that it was doing what we hoped it would do, we would be very hopeful to offer it without charge to more patients, but obviously everything comes at a cost. And sadly, you know, NHS tariffs don't necessarily cover the costs, and you know, working within the NHS, it is difficult. But yes, we will be evaluating it. We will do what we can, but we haven't done anything with it yet.
Great, thanks for that honest answer. So we've got an anonymous question. Someone says, is part of the problem because so many people just have unexplained infertility, and therefore there's no clear diagnosis to lead to a treatment pathway, because it's sort of, I think I've heard people argue over the years that, you know, there's this rush to treat, well, not to treat the underlying condition and to investigate the underlying condition, but just to leap straight forward to IVF because it provides the potential solution of a baby. So I don't know who wants to go first with that one. I mean, Rachel, from your time as an embryologist, did you see this as an issue, that this, because so many people do have unexplained infertility?
I think it's always very difficult if somebody does have unexplained infertility because you haven't got an answer to why that is. I mean, I think this is a very clinical based question, and it would be, you know, really directed to a medic, I think, that would be on the call. Certainly in my practice, we wouldn't have rushed to offer an add-on within the laboratory unless we felt that there was a genuine reason, regardless of the type of infertility.
Yeah. And Kate, you must have experienced a lot of people coming with this issue over the years. Is this something you'd like to comment on?
I just think it's always a really difficult diagnosis or lack of diagnosis, because it leaves you very vulnerable to all kinds of different things that you might try because you don't know what it is and you don't know what might make a difference. So yeah, I think it does make things more complicated, but yeah, I'd agree.
Okay, so I'm going to go now to a question from Satanu Acharya. Apologies if I've got the pronunciation of your name wrong. There would be right things written on websites, but that doesn't mean that the right advice is given. More importantly, sometimes this is patient-driven, where it's very difficult for couples to accept that nothing could be done, especially after a few failed IVF cycles. What happens if they're still willing to go for add-ons, given lack of evidence doesn't mean no evidence, given the research in many of these is at best limited? So what do we think about that scenario? I don't know how we can help those people really with the proposals. Rachel Gregoire first, and then Rachel Cutting, perhaps.
This is an interesting question, because I know within the workshops, we actually, when we were debating about information being provided on clinic websites, we were almost moving towards it should be less. As in, that's not the function of the website. It should be almost, this is what we do, you know, these are the types of treatment we can offer, and this is the evidence or lack of, and this is the HFEA website link. This is what we can offer. And then only in the clinical setting with the clinician and the patient to have that really sort of individualized conversation, because otherwise to determine what sort of treatment is best for them. So actually more advice being given in the clinical setting rather than the website, because the website could potentially allow patients to feel that that is right for them, that this will be something that will benefit me, when actually it won't, and it shouldn't be offered for this particular patient. So we were actually moving towards less information on a website and more within the clinical setting, because this is what is right for that patient. It's not overwhelming them with all of these different types of treatment.
Does anybody else want to come in on that? Or
I think just to say that it is very much a clinical decision, and it is a conversation between the doctor and the patient, or if it's an embryology add-on, perhaps an embryologist having that conversation to explain to the patient why that add-on might not be appropriate for them, because patients are very well informed. They do their homework, they research a lot. They may know someone who's had an add-on when it's worked for them, so it might be that they think it'll work for themselves. And if a patient, really does want an add-on, it's up to for them to make an informed choice and informed consent, and that to be documented well, and for the doctor to explain that to the patient.
And Kate.
I think I'd absolutely agree with what Rachel's just said. I think it does have to be an individual choice by an individual patient about what they want to do. But one thing I find quite interesting is some doctors now will actually say to patients, you could have this, but it would be a waste of your money. I wouldn't want you to waste your money on this. And I think being that honest can actually be really helpful, because ultimately patients do need to know the truth. They do need to know the reality of whether something would actually really genuinely make a difference to them. And the only opinion they've got is the doctor sitting opposite them. And I think sometimes actually being quite blunt and saying, well, yes, you could do this, but I wouldn't advise it, is really helpful.
Yes, it may not be the news you want to deliver, because no one likes to say they can't help and refuse things. But actually, and that I think ties in with a comment from Nivedita Reddy, who says patients often ask about add-ons, and it's sad that many think these extra benefits are only available in the private sector and not within the NHS. But when you explain and give them the facts and the lack of evidence, they do accept. So I think that sort of just actually reflects what you've just been saying, really. So it was quite nice comment from her. So and I think it's a point that Roy Homburg, who I know is on the call, that he often makes that point as well, that giving telling people the truth and your reasons why that you don't think that is really important. And I notice he's posted a couple of questions. I might get down to those in a moment, but I was going to go next to something that Hannah Horn-Robinson said, and I thought it was quite a good point, because I don't remember this coming up, and it ties in nicely to that last one, because it's about communication. And she says, I don't see on the proposals list training the doctors and clinic staff on how to communicate. Creating worksheets is not enough, and patients often get information from each other because we know how to communicate in a way that makes sense to us. And was this discussed in the proposal process? Now, I don't recall it. Manuela, do you remember it being discussed?
No, I don't recall anyone suggesting this, but I'm happy to collect further suggestions for future projects. So if you have any, please get in touch.
And I think the British Infertility Counselling Association, if I can say it, do run workshops on breaking bad news for clinic professionals, don't they? And I don't know whether that's incorporated into that. Does anyone know if that's the sort of bad news, or is it actually
just treatment? It's just bad news, yeah. But I think you would hope, and I would encourage anyone to feed back to their clinic if they felt that the information wasn't clear or that communication wasn't as good as it should be, because it is, certainly within NHS clinics, all the feedback is reviewed quarterly. There are patient representatives that feedback. We're actually offering some almost, want of a better word, customer service training for our staff to improve that communication. And also all the information leaflets should be passed by a patient experience team to ensure that it is in the, in an understandable language and format and so on. So definitely feedback to a clinic if we feel that the communication isn't what it should be.
Great. Does anyone else want to come in on that? But perhaps something that we need to think about taking away, particularly to Beaker, to perhaps incorporate into their training. So that could be a nice little thing for them to do. So the next thing I'm going to ask is, I just lost it in my list. If this is an anonymous one, if the add-on is available in the market regardless of proven efficiency, desperate people will buy it. Should they not be permitted in clinics to offer unless proven? I think that sort of goes back to perhaps something in my opening, you know, when it's not always that black and white, is it? I don't know. Does anyone, we didn't have that as one of our proposals, that they should just not be, they should be banned or not offered at all. Does anyone want to go that far or add some nuance to that? Rachel, Cutting.
I suppose it goes back to the limited powers of the HFEA and what is deemed a suitable practice. And we also have what's an authorised process. But then there's lots of add-ons that come underneath that, or slightly outside pre-treatment or post-treatment, that isn't covered within the HFEA. So this is the sort of information that we need to gather and think about when we go forward with the law reform work.
Well, we're certainly not going to be able to ban pineapple cores and fluffy socks, you know, but joking aside, you know, I mean, the expense of those is somewhat trivial, and probably do no harm, although I think it might harm my teeth if I chewed a hard pineapple core. But there we go. Right, Rachel, Gregoire, did you want to come in?
Just that if currently every clinic for every add-on should be referring to the traffic light system, and that it is clear about the limited evidence, and their information should be clear about, and also about potential risks. I know, Manuela, I think you mentioned it earlier on, and I thought I do want to just go back to our own patient information leaflets and think about those. Are we being clear about potential risks? We talk about lack of evidence of benefits, but it's just, I wrote it down when you said it earlier. And I think if our patient information leaflets are clear, then patients will make informed choice. And it is, as a clinic, worrying that it sounds ridiculous, but if you don't offer a treatment, the patient will potentially go elsewhere and be exploited. Whereas at least if you offer and you can talk it through, and we do tell patients they shouldn't have something, we don't think it's of benefit, you feel that you're trying to look after someone that's come through your doors. It's a difficult position. You want to be able to offer it to those that you feel it could be of benefit for, but also you have to say if you feel that it isn't the right thing for that patient to do.
Can I just come in, Sarah? I mean, I think on this call, we are all concerned about how add-ons are used. We want ethical use of add-ons. We want the right information to get to patients. And as much as we drive this, it sort of seems like the elephant in the room at the moment, but it's the commercialism of this. If you're selling add-ons, you're bringing more money into your clinic, and we can try and make add-on use be ethical, be the right information, but how are we going to address that add-ons do make money?
Okay, we can't get away from that. So someone said perhaps part of the issue is that it is natural for patients to want to understand why treatment has failed, and the process of managing their concern is using certain add-ons to provide an answer. So, for example, PGTA in recurrent loss or implantation failure. This may not improve live birth rates, but may help some patients rationalize why they keep failing and move on to either closure or, for example, donor eggs. So any database should include the reason why that add-on is being suggested. And I'm always loath to agree with things that add more to people's workload, but that, I don't know, do the panel think that actually seems like we'd have to, you know, it would be sensible to include that at the same time as if you're collecting that data on add-on? Quick thing, why? I don't know. Rachel, Cutting, could PRISM cope with yet another load more data collection?
I mean, PRISM can have things added to it, but we do have to go back to what I said in my talk about what the sector wants as well. And when IFQ was done, the project, you know, we don't even collect cause of infertility now because that was deemed burdensome by the sector. So we would need a change of attitude, I suppose, that everyone is willing to submit data, and then obviously something needs to be done with that data. So I think there's some steps to go before we do collect that. I mean, we do collect data on PGTA now. You know, we do know when PGTA is used, but the reason why sometimes it's not always clear cut, is it? And again, that's why we've got the information on the HFEA website on the add-ons and the nuances there, that while PGTA isn't suitable for everybody, it can be very useful and very helpful in specific circumstances, such as for advanced age. You know, there is some evidence there for advanced age and miscarriage. So we do try and explain that it can be useful in certain populations on the website.
Kate.
I think if we could have that information, it would actually be incredibly helpful, and also possibly help patients in their decision making later on as well. And I don't really think, I appreciate that clinics do find it potentially burdensome, but we've just been talking about the commercial nature of add-ons and how much money clinics are making from them. So I think maybe the downside of making a lot of money should be that you also have to provide some data about what you're doing.
Yes, indeed. Anyone else want to come in on that? Okay. There's a few questions about clinical trials, which is always inevitable when we talk about fertility treatment add-ons. So someone's asked, is it even possible to do wide-ranging clinical trials, considering different people have different causes of infertility? And then there's another one actually from a comment from Roy Homburg. Every discussion on this subject concludes that we need more good quality evidence. Anyone knows that attempting a well-powered RCT on an add-on in the UK needs enormous funding and unending patience to deal with the interminable bureaucracy. When it is possible, e.g. Priya Bede's recent study on time-lapse will change clinical practice. We need research to be made easier to do and encouraged. Until then, there will be no more discussion on whether an add-on is good or not. So it's you know, I suppose, do the panel think that some of these proposals will be you know, at least a sort of decent substitute for while we're waiting for this evidence, if we ever get it? What do you think? I'll go to Rachel Gregoire first.
I think yes, and I think it was, as Manuela said, it's also to understand who is being offered it and what and why, not whether even that it works or not. I think when patients are looking at different clinics and trying to determine where they're going to seek treatment, there is limited information about the type of treatments they're offering and how often they're offering it. If you look at our clinical success rates, for example, there's a lot of add-ons going on there in the background as well that they don't know about. If they're if they're doing using the Choose Fertility Clinic page from the HFEA. So I think it is of value. And I think because of the difficulties for RCTs, clinical trials in the UK, and the funding, it's all we have. And the data is there and we're reporting anyway. It just seems a waste to not gather that information and use it as best we can.
Great. And any of the panelists want to come in on that?
May I just add 2 comments to this last comment? 2 of the proposal were dealing especially with the cost of producing evidence. They were probably those that were considered less feasible, which were using part of the potential profit either from suppliers or clinics to fund the RCT, because we are aware is expensive. They are expensive and evidence production is costly. There was a certain level of, let's say, not much trust that this is going to happen, that this sort of funding is going to be collected in order to support the evidence production. I still believe there is an ethical argument to be made that I personally don't think that banning add-ons is the solution, but the fact that profit can be made on something that is not supported by evidence should be an open conversation. It's a very different conversation, not about the providing an add-on, but marking it up significantly or selling at a cost that is very higher than the rest, for instance, of the average. But we're back to the same problem. We don't know what is the average cost. We don't know. There are estimates. There are no real data on how much this thing costs, on how much these things are charged. And therefore, it's very difficult to have a meaningful conversation. And the second point regarding the evidence, it's concerning to see that the ESHRE, in the first page of their paper, acknowledge that there is a generalized low quality evidence. I think is a problem, but it's even more concerning considering that at the end, I'm not very sure that the practice is going to change. I believe there is quite a certain consensus that time-lapse doesn't increase success rate. And I've been studying this for 10 years now, and I'm aware that it's an incredible tool for many other things, for the lab, for the knowledge production, etc. But does it mean that when the evidence is there, then this is not going to be offered to patient anymore because it increased success rate? I think the communication is the part that should clearly change. If a patient will time-lapse because they want to support evidence production, is a very different reason rather than because it might increase your individual success potential. I think this should be made clearer.
And in relation to evidence, Rosanna Crawthorne has just posted, has NIHR been engaged in these conversations about research in this area? I don't know whether you did reach out to them, Manuela, or not. I don't think I remember doing it.
No, we haven't reached out to that. The project reached out to a lot more actors that we planned originally, and the idea is to continue next year looking into more potential connection. So again, if you have any suggestion, we are collecting those for future projects.